Are you anxious about using a hospital bed in your fieldwork or your first OT job? This video will provide an overview and go over some tips that I have learned over the years to make your job easier and keep your patients safe when working with the hospital gurneys and beds. Hi, my name is Jeff and I am an occupational therapist. I make occupational therapy content on my blog, ot.dude.com, social media, podcast, and regularly here on YouTube. If you're interested in learning more about what occupational therapists do, be sure to subscribe to my channel so that you don't miss a single video. Also, check out my free resources in the description below. Let's get functional. The first thing I want to mention is to follow your facility's guidelines and the user manual for the hospital bed at your workplace. While I cannot go over the specifics of the model that you will work with, electric hospital beds share many similarities that I will be able to go over in general. You probably had this drilled into your head in OT school, but it's a good reminder because I have had some close calls myself with hospital beds, especially during transfers, and that is to lock the brakes. But not only that, check to see if they are even working properly. Even if the brakes are locked, if they are worn out or just plain not working, you will want to know before it's too late. I like to just use my legs to give the bed a little nudge to the side and to see if it moves easily. If it doesn't move and it's locked, then you are good. Another thing is to not put your patient or other coworkers' safety in danger. If you need to move a hospital bed, such as to make room for a wheelchair or whatever the reason, the first thing you should do every single time is to lock the brake afterwards. Some beds have alarms that go off if the brakes are not locked or engaged, but not all beds have this feature. Also, if you move beds around, make sure you do not accidentally disconnect the call button cord. I've done this probably hundreds of times, but the key is remembering to plug them back in. Sometimes there will be a call bell that goes off when this happens, but again, not all facilities have this feature built in. The controls for the brakes usually look like a long flat lever. One side is for brake, red color usually. Then there's neutral or horizontal lever, which allows all four wheels to move. If pushing a bed by yourself, especially around corners, but you don't want the opposite side of the bed where you don't have a helper to move, it's best to use steer mode. In steer mode, two of the brakes on the patient's head of bed lock up and allows you to easily pivot the bed. This is a very useful feature because otherwise the entire bed can move away from you, especially when you are alone because no one is controlling the opposite side of the bed for you. One way that I remember this is to think of steering mode like a car. Two of the wheels in the back just go forwards and backwards, but the wheels in the front, where the driver is, by the hood, can steer left and right. So the hospital bed kind of does the same thing. In neutral, all four wheels can go in any direction, so be very careful of that. Some of the newer beds have power assist to help, say, one OT push the bed. I haven't used these, but just be aware that they're out there on the market. When moving the bed, either on the wheels or using the controls to adjust it for the patient, be careful of cords, lines, and other objects. This can be call bell cords, cell phone charger cords, Foley catheter tubing, IV lines, or even body parts in patients, such as with neglect after a stroke, for example. While still on the note of safety, another thing to look out for is patients slipping out of bed. So don't leave things like slip sheets used for slide sheet transfers, air mattresses that can inflate, or even an elevated bed for patients who are fall risks without any safety precautions. Patients have slipped out of bed from these sheets or inflated mattresses without bed rails to prevent such falls, or even better, if these types of sheets were removed altogether. You may want to put 3 rails up when finished with therapy. If you need to even step away for a split second, make sure the patient cannot easily slip out or fall out of bed if they are at risk for doing so. Intuitively, it makes sense to have all 4 bed rails up, 2 for upper torso and 2 for the lower extremities on each side, but many facilities and regulations now consider this as a restraint. Check with your facility for what you should do in this case. Some therapists like to have 3 rails up and use an additional barrier as the 4th, such as a bedside tray. This also depends on your patient's safety awareness, cognition, level of agitation, etc. Okay, let's talk about bed alarms. This again depends on your facility, but even the unit you are on can have either a strict bed alarm culture or a more lenient one. Even in the same hospital where I work, one unit may want to use bed alarms pretty much all the time, while the other unit is at the staff's discretion. Test to see if the bed alarm works also. Some may run on batteries and the batteries will need to be replaced. Sometimes beds get serviced so often and they fail and need another service or need to just be put out of service entirely. Some bed alarms have sensitivities that can be adjusted based on how the patient moves and their positioning. Psychologically, there's a balance between safety and making the patient feel like they're not in jail, for lack of a better phrase. There is no perfect alarm setting that is one size fits all. It really depends on the patient and how they're moving and their level of safety awareness and so on. So coordinate with nursing and other staff with that. When mobilizing patients before and after, remember to disarm and rearm the bed alarm. Trust me, you'll forget probably many times like me, but one thing to learn is how to turn them on and off. I prefer the older style beds that have either just bed alarm turned on or off, and it's usually like a press of a button. But newer beds are more sophisticated and kind of more annoying in my opinion because you have to fumble through some more menus to disarm them, and some have time delays and the alarms go off later, like after you have mobilized a patient and out of the room or in the bathroom, for example, and then the nurses come running towards you because the alarm goes off. Let's talk about the beds themselves. I like to classify hospital beds into two general classes. There's the regular and there's the bariatric. The bariatric beds are similar to regular but often have bed rails that instead of coming straight down, instead they kind of swing out. Of course, that's not always the case, but just know that there are different ways that the beds move in terms of bed rails and other parts. Bariatric beds also, of course, have higher load capacity, but many of them feature air mattresses to prevent pressure injuries. Learn how to inflate and deflate these when you mobilize a patient. What is nice about a lot of the newer hospital beds is the new air technology in the mattress to prevent pressure injuries is built right in to a lot of them already. For patients who are on the taller side, they can probably use a regular hospital bed with like a leg extender piece, not necessarily have to use a bariatric because those are more for like the width. The nurses and CNAs often install this upon admission, but sometimes the equipment may not be available and may be added much later. In shared rooms with neighbors, such as two patients to a room, one trick that I learned from a CNA is if a bed is blocking the path at the foot of the bed, usually for a patient in a wheelchair walking past the foot of the bed, if you raise the head of the bed up, the one that's blocking you, the bed will take up less room and free up a path for you and the patient to pass. This again depends on how the hospital bed moves when raised and lowered, but the ones at my hospital did this and it was really nice because you did not have to unlock the bed and pivot out of the way, move the neighbor's bed out of the way, move your patient out of the room, move the neighbor's bed back to the position it was at, and remembering to lock all the brakes. Sometimes in acute care and acute rehab, inpatient rehab, I feel like I rearrange furniture more often than not. But patient safety first, right? So let's talk about bed controls. Obviously, they can raise and lower. This comes in handy when dangling and if your patient is short or tall. An elevated bed also makes it easier to sit to stand. If you want to grade the activity up, lower the bed. Also keep in mind that some beds do not go very low to the ground. If your patient is a high fall risk, then they may need to have their bed switched out for a bed that can go lower to the bed. One tip to save your back is to raise or lower the bed when working with in-bed ADLs. Work smarter, not harder, especially on your back. The head of bed can raise or lower, of course. Oftentimes this is linked or paired with the lower extremity side of the bed. This is kind of what it looks like. Pretend this side is the head of the bed and this side is the foot of the bed. When you raise the head of the bed, sometimes the bed is linked to the foot. So when I raise it, this may kind of go up to make it more comfortable for the patient. But if you're doing things like dangling, you may of course want to keep the foot of the bed flat so that it does not create a hump that's more difficult for them to sit up from and just only effectively raise the head of the bed. One trick, if you do not want the lower extremity side to move and just to move the head only in a paired or linked bed, is to simultaneously press both the upper and lower sides together as you raise or lower the head with the opposite, the lower side, and see if it keeps and stays still. One other control is the Trendelenburg and reverse Trendelenburg feature that can tilt the entire bed into Trendelenburg or reverse Trendelenburg position. This can come in handy if you're doing a boost with another staff member, say to slide the patient to the head of the bed, and especially if the patient is more dependent or of a larger body habitus. Because if you use gravity to your advantage, it'll make the job easier for you and your partner to slide them up, say with a chalk pad or a sheet. By the way, if you get the chance, take a look at some of the chalk pads because some of them can support actually a lot of weight, such as up to 300 pounds or something like that. It's quite impressive. Just remember to flatten your patient's bed out so that you don't leave their bed in Trendelenburg and leaving the blood rushing to the head in an upside down position. And be careful, especially of this with neuro patients that have strict head of bed up orders to prevent things like bed flat even or even upside down. You may also notice a CPR latch or button on the bed. Usually it's red. Remember where this is located in case you need to perform CPR because you will lose valuable time slowly waiting for the bed to come into flat supine position for chest compressions. So that's what this latch does. This changes the position, but not really the hardness or firmness of the mattress, just the flatness of the entire bed. You may still need to do a log roll and slip a hard firm board under the patient to harden the surface under the patient in this case. Most hospital beds now have IV poles that pivot and fold away, a place for the oxygen tank also, and a place to hang Foley catheter bags on either side towards usually the foot of the bed. You don't just hang them anywhere. Because we often plug things like SCDs towards the foot of the bed, it's nice that some of the newer beds actually have power outlets towards the foot of the bed so that we don't create fall and trip hazards from running electricity cords all the way from the head of the bed. I've seen this done dozens of times when there's actually an outlet towards the foot of the bed. So educate the whole staff if you discover this and you see it happening repeatedly, because I've almost nearly tripped over electrical cords, let alone my patients, when mobilizing in and out of bed from these extension cords basically running all the way down, and there's usually more than one of them too. So huge trip hazards. Even if you tuck them under the bed, they somehow come out and get in the way anyway. So look out for that. If you teach this to your team, they'll love you for it. Also, pay attention to where you can tie quick release restraints for patients who may be combative, for example, because you can't use just any place to tie down your loop you find on the bed. Some areas move, like the head of the bed, and you don't want to yank on the patient's extremity or something accidentally. You want it to be more of a stationary place that doesn't choke the patient or anything, that is made to be a tie down spot. So pay attention to where those are too. Overall, these are the major points and tips I wanted to go over. Of course, it's only a broad general overview. Check out some more videos on YouTube and ask your CI or team for an in-service during an orientation on hospital beds, or especially if you get new beds for an in-service, especially because the newer ones have touch screens and multiple menus to control things like bed alarms with time delay features. Ask how to change, for example, the language from, say, a foreign language back to English too. I've had to deal with this before too. Give this video a thumbs up if you like this kind of content, and thanks for watching.